All right, good morning. I got the thumbs up from the back of the room. So welcome on our last day of a great conference. Hopefully it's been good for you. We try to make this interactive. So I have a full set of disclosures before the disclosures. So I am at that age where I have my glasses on to see you, have to take them off to read. So hopefully you won't get distracted by my non-bifocals here. The other aspect is they're always fogging up, so if someone has a great tool besides pitch, I can't pinch any further. I think my eyes breathe. So that ahead of time, and unfortunately, I didn't get a lot of sleep last night, so I have my coffee, and I had to bring my little guy with me to the conference. So I did get him settled. He will hopefully just sleep for the remaining of my session, but I might have to care for him at some point. So hopefully you're understanding, and he didn't really adjust too well to the time change. So welcome to the session on the role of diversity in patient-centered care, and really starting to have a dialogue around this around the nation, right? About how simulation can help our learners understand the fundamentals. So that is going to be our focus. I'm going to give you much more examples and questions and probe you a little bit than solutions to every problem related to how you do it under the sun. My name is Dr. Desiree Diaz. I am an associate professor at the University of Central Florida. I am the undergraduate simulation coordinator, but more importantly than all of that, I am a simulationist just like you, trying to tackle some of the situations that we have currently and really trying to make a change. I always say one ripple at a time, because we start off in education and hopefully it ripples down to transition of care somewhere. You'll notice on some of my slides I do have the Laerdal mark. They were a funder of one of my major healthcare disparities grants, as well as providing support for mannequin usage throughout, so just giving them credit. Part of the other disclosures that I have, some of the slides and content I have previously presented. It is really, you can't change a good article if it's a good article, so I want to make sure we share that. So if you've seen some of these examples before, especially because modern healthcare, right before the pandemic hit, had a well-viewed conversation with me around this topic. So really trying to tweak that so it's not hearing the same content just packaged in a different way. So hopefully I'm bringing you something new today. The objectives is really to gain an understanding of how someone's unique racial, ethnic, other identity really impacts patient-centered care and what that means. Really understanding of how someone as a person of color might feel when you say you don't see color, well then you don't see a lot of me. And not because of physicality or the tonality, but what that actually brings to the table when you interact with me, and what that means in regards to culture, interactions, and as well as healthcare expectations. The next objective is understanding how we can use patient simulation to help our learners, really the impact of diversity on patient issues. And I think this is a really important topic for us, because as it seems like everywhere you turn, there's someone being quote unquote, I hate it when they say woke, and they're woke, but all of a sudden you are being bombarded every corner you turn. Kelly Bryant and I were talking over Christmas break, and I was like, man, I have never seen, and if you heard me say this yesterday, I apologize, but it's just profound to me. I have never seen so many brown-nosed gnomes, My entire life at Christmas time, there was always a white Santa, a white nutcracker, white gnomes, white elves, and now this year I saw life-size nutcrackers. Even Dollar General had, multicultural, I don't know what you pretend people, because I know an elf isn't real and a gnome isn't real, so, those people, whatever they're called. So it was very interesting. Again, though, I don't know who's paying $500 for the life-size nutcracker that I saw at AC Moore, but it was kind of cool. So before we start really delving into this topic, it is important for you as people that are starting to use simulation in healthcare disparity or racial implicit bias, whichever content, it's all visceral, right? It elicits a response when you say, oh, a person of color, or someone who is from another background. So be upfront with your definition. So these are my definitions as we go forward. A person of color is defined as anyone other than white. So that includes Black, Asian. A lot of times you only hear healthcare disparities related to Black and brown people, but as I was reminded yesterday in our panel discussion, that Asian population falls under the people of color. Hispanic is anyone with Latin heritage deriving from areas, which I think is key, prior to entering the U.S. So my husband was born and raised in Puerto Rico, and there's a cadre of people that don't like the term Latinx. I had no idea that it was derogatory. He's like, we're all Hispanic. We are all Latin. And in talking to some of the panel members yesterday, they were like, yeah, I have people on both sides of the spectrum. So just identifying and defining what you're using the terms as really helps people understand where you're coming from. LGBTQ plus are individuals who self-identify in any of those categories. I know there are additional letters for the mnemonic. Having been on a World Health Organization panel, well, I wasn't on the panel, I was attending, back in June, those aren't even the same initials used worldwide consistently. So I choose to just go with LGBTQ plus because the United States, we tend to be very ethnocentric and say these are our terms, this is what we use, but other places around the world have different letters. So that's what I'll be referring to. So let's start off with past as prologue, and what does that mean, and where are we currently? So back in 2007 is really where I started my DEI journey as an educator, okay? And in that journey, I started to notice that there were only white mannequins everywhere. I was a director of a 4-site simulation campus, and as I was trying to fiscally figure out how I was placing mannequins places, you know, on each campus and everything had to be equal, I noticed minority mannequins or dark mannequins cost $10,000 more than the white mannequin. At that time, there was no brown, it was black or white. That really bothered me. That was the start of my dissertation area when I was doing my doctoral work, and I couldn't understand it. I was just a newbie in the field, but I couldn't take it any longer. So at the National League for Nursing, they had a town meeting, and at that town meeting, there were higher-ups from, I think it was Laerdal. I know the NLN president was at that town meeting, and I just went to a mic and I said, how can you value me more in plastic than you do in person? And then there was just kind of like a dull silence, and I was just like, that's just how I feel. You're asking me to manage $80,000. Well, I could either buy 3 mannequins or 2 of color and have some diversity. How do I justify not having all that I need because I wanted to add color? That's not fair. So I got the regular responses that we are all now privy to 14 years later, that it does cost extra because they have to stop production to add the dye and the pigment, and I don't care. I don't care what you have to do for me to be represented. And then we got that taken care of, so now the prices amongst all the companies are equal, thank goodness. But then, why is there a 4-month delay on a minority mannequin? Can't you make some in stock? Can't you have some there? Because if I'm starting a study, I need to start because I have deadlines to meet. So it really starts a whole conversation and dialogue about how is industry really impacting and affecting research outcomes, which really mimics reality, right? We know all cardiac meds are done on white males over the age of 40. Well, there are females, there are minorities that are affected by that too. So how do we change that? Well, going on 10 full years in the literature. Cynthia Ferranda, Cindy down at University of Miami, they looked at, said, you know what, let's look at advertisements. Let's look at the black and white pictures in what we can purchase. If you notice, all the catalogs are all white mannequins. And then they have a subset, if you'd like brown, if you'd like black. Why not show the black mannequin and say, if you'd like white? It's up to us to change that. Is it that they think white is more readily sellable? I don't know what their discussion is of who gets to be in the advertisements, but it's our job to change that. So then we go on. Crystal Graham in 2018 really looked at nursing students. How do you feel when you have mannequins of color, all colors that represent you, versus white mannequins? And it was shown no different than our patient population. You feel better. You feel like, oh wow, you see me. You see me. I'm not in your world. We're in this world together. So I think then we started to have this discussion. When we looked then in 2020, so just 2 years ago, there was still minimal diversity in skin tone, age, and sex. Now what starts to happen in 2020, right? Because that study really took place in 2018 by the time it gets to publication in 2020. So now we're in the pandemic. Now we have people at home starting to fix the problems, starting to see how can we make avatars of different colors? How can we make task trainers? You heard yesterday that task trainers are even well beyond where we are with the high fidelity mannequins. Well, nothing really seems to move, engage, and then Sharni and Farr said, you know, we got to get past that. We got to get past the tonality, and that's where it starts to intersect with my research. Don't judge me on the tonality of my skin because you don't know what's underneath my skin. So what is the context for that with us in simulation is we have to get past just the mannequin. What is the content that we're going with that mannequin that we're starting to use? So are you just saying the typical, it's a 35-year-old black male with hypertension? Well, there are other people that have hypertension besides black males. What are you doing with that content, with that descriptor? Within our society of simulationists, there is a whole discussion. Do you use race and ethnicity in the descriptor of the case? Well, if you do, make sure it's pertinent. You don't need to say someone's ethnicity if it's that they got a cut on their leg. What does their race and ethnicity have to do with the cut on their leg? But now maybe if it's diabetes and it's a non-healing cut and they're back and forth and you want to pull in some of those factors, well then sure, make it a Hispanic male, female, that make it a male who's really not in charge of their cooking. It's usually matriarchal, and then pull in all the things. Well, he's eating the rice and beans every day. He's not taking his insulin. This wound isn't healing, but make it purposeful. Then we go into the study that is to be published, hopefully. I got word this morning from the editor. It's supposed to be out in May, but they've had it since October. That we looked at, okay, let's take a healthcare disparity scenario. And let's just look at if there's difference between people that self-identify, so we had no criteria to, if you self-identified as a person of color versus someone who didn't identify as a person of color. How did this healthcare disparity scenario affect you? So we, well beyond my statistical ability in my doctoral work, in the classes that I've taken, so we had a biostatistician on here. And all the students loved the scenario. They learned from the scenario, set M scores were high, but there was a significant difference between minority students and non-minority students. And then when looking at their written in, it was great to finally feel like you're addressing my needs. My family is here. So on top of, yes, it's a great scenario, they're like, wow, thank you for seeing me. Thank you for addressing something that I deal with every day. And that's really important for us, or should be important for us as educators. So that's kind of our past. Now, where are we currently? Currently, we know simulation offers an opportunity for critical thinking, but as our plenaries have challenged us, are we ready to be able to have that safe place for someone to really express how they're feeling when it might not be the most politically correct opinion? It might not be what you personally agree with. Are you ready to accept wherever they're at and hopefully give them data, help them see so that they can change? You can't make somebody change. True change. You can force them, but then it's just pretend. So true effective change is layer by layer by layer. So then when we look at that, okay, can we have that in-depth, deep reflection, and how do we start? So we know we need to have it in the pre-brief, so get your learners thinking about these topics prior to simulation, prior to them coming in front of you. So if you send out an article, whether it be about healthcare disparities, implicit bias, something that they're starting to think, okay, well, how do I feel about this? But they're in the privacy of their own home, they're wherever they are doing the preparation materials, and can start to foster some of those ideas so that when they come into sim, it's just not that they're talking off the cuff. If anything, right, we've all experienced they go silent. And then when we're looking at all of diversity, equity, and inclusion, we also have to think about the implicit bias. We have to allow the learner to know some of these things we had no choice. We grew up in an environment where we thought whatever our parents told us was correct. Now it's trying to undo that and seeing different views. And are you ready for that? Are you ready to help your learner figure out how do they do that? How do you tell someone, yeah, what your mom and dad told you for the last 22 years, that's not really cool. You can't do that here. Well, what's the why? My parents, are you saying they're not good people? I mean, there's a lot of things that are embedded in that. And understanding an idea of inclusivity and what does that truly mean to you. So here we go. Well, there's Mike. So I'm going to put up a picture. I'd like to have this little activity. Tell me what you see. Yeah, no, not that. So what do you see? On the first picture, what do you see? Okay, 60-year-old African-American coach, high school. Okay, a little overweight. Okay, could be a health factor. Anyone else? Go ahead. Okay, pretty happy, pleased with himself. Okay, hang on, now I need to do this. I see your hand over there, but go ahead. Anyone else? Go ahead. Okay. Anyone else? What about the lady? Looks what? Okay, looks Latino. Okay, looks like a mom. Okay, mom or grandma. Anything else? Any health things? I think there's surgery there. There's a line there, I think. Hang on, let me do this one. Yeah. There's a line there. There's a line there. Really has, yeah. Okay, so well dressed. Okay. Hair's good. I'll be sure to tell then that, hair is good. So on the right, I heard African American, happy, high school coach or something. Okay. Maybe a little overweight. On the right, I heard no real health issues, but a grandma-like, well-dressed Latino. So these are husband and wife pair that I know. The wife really takes care of the husband because he has severe glaucoma. So usually when I show this picture, they're like, oh, she looks tired, worn. He looks happy. Yeah, because she's doing everything for him. So he looks happy. He is actually a coach, but here he is hunting. So I had to get permission. So listen to some of the things I'm saying. I had to get permission to show this specific picture of him from the wife, not from him, because what she said was, I didn't want people to think he was dirty, tattered. He has clothes. I tell him not to wear that out. And he was like, yeah, I look good. Look at my beard. He totally did not care. Now, with her, we already discussed that. So here's an elderly couple. Can we use them in the scenarios? Now, she is not a Latina. She is from Guyana in South America. So all of South America, just so you know, is considered Latina, but it is English-speaking country, one of the only ones in South America. Well, but they do speak Spanish. But anyway, that is what it's defined as. So she wouldn't consider herself Latina. So he wouldn't consider himself African American. He considers himself Caribbean. He's from an island. So again, we all make assumptions going in to see people. And how do we ask? But do any of the boxes I just say, are they there for us to check? So how do we teach our learners how to ask those questions in a respectful manner? So that brings us into implicit bias, right? We all had a bias going in. We look at two people. We assume certain things about them. We may or may not have thought the male, was disheveled, but happy. He was happily disheveled. We knew he wasn't lacking food, or we made that assumption. Just because I'm big belly doesn't mean I'm eating the best food or the most appropriate food. What do we know about shelters? Very high salt content, high carb content, because it's canned food and breads or pastas. It goes a long way. So when we think about our implicit bias, we need to let our learners know when they're walking through the door what they're bringing with them through the door. Now, you can go to the Harvard implicit bias. Yesterday, I think our entire group session had taken the implicit bias training. Have any of you done that from Harvard? Have any of you done all? I think there's like 20 of them. No, I've done a select few. I have not done them all, but I can tell you on the ones that I have done, I'm like, wow, I don't have that bias. So it's self-reflection and even thinking, oh, wow, all right, well, maybe I do. Maybe there is some truth to it. Outside of all their research, we still critique it, right? Well, that's not true. I personally said, oh, it's more of the yes, no on the toggle. They're more testing that than if I really have a bias on how fast I do it. But when I reflected, I was like, okay, I can see that. That potentially, that is something that I might need to be aware of. Now, how does that impact our patient care? What's your thoughts on that? How does implicit bias impact our patient care? Anyone? Go ahead. Go ahead. Okay, so you might miss something that's really important. Okay.
You can change the way you ask questions by that implicit bias. So
Okay, okay, go ahead. Which brings us to what everyone is aware of, where black mamas and babies actually are dying 3 times the rate of their non-Hispanic white counterparts. Now, that bias, can we change it? Can we affect it? Well, if we know that this is already going on, how come it hasn't changed? I was at dinner last night with a colleague who is not, she's medical, but not doctor, nurse, she's a respiratory therapist. She was like, what is going on with all these vaginas in the showroom? She's like, I've never seen so many. She goes, I understand that, I guess she asked someone, and they said, well, now the factor is you hear it everywhere. Black and brown mamas and babies are dying, so now everything is about maternal child infant mortality. And I said, yeah, that's probably what's going on down there. But interesting where I'm kind of blind to that, of what's out there on the show floor related to body parts. But she was really taken aback from that. Because as people start to be aware, we have to go beyond awareness, because that's just stagnant. Now, what are you going to do about it? Well, here's some other stats that we don't talk about often, and I want to focus on the Asian American and Pacific Islander men have 57% more likely to die from liver cancer. Yesterday's session, and some of you were in that session, we had a colleague from California who was Asian descent, and she said, and it really stuck with me, and I thought about it all night. She said, as a person of color who's Asian, I don't feel seen. I don't feel that we discuss these topics related to me. So I really wanted to make sure we're aware of some of these other stats. It's not just, typical black and brown people. It's all people that are non-Hispanic white that are affected by these healthcare disparities. Now, we have to go a little bit deeper and look at what is causing some of these factors, right? It is not just the color of their skin or where they're from. It's people not providing the adequate care across the board. And as we start to talk about these conversations, it starts to get uncomfortable. Are you really saying people aren't getting the same care and the same treatment because they don't look like their provider? Yes, that is what I'm saying. So how can we change some of that? And it's really important, and I keep saying it's really important, but it is, for us to provide our learners the ability to be health advocates. Health advocate means that you're doing something about it. So it's not just pulling them through a sim, you gave them the pre-brief. What are they doing about it? So people say to me, the students, all the time, Dr. Diaz, I'm not going into labor and delivery. Why are we doing gestational diabetes, healthcare disparities? And I'm like, well, you will see this mom somewhere, right? You're going in healthy. You potentially can see her in the ER, and she's coming for uncontrolled blood sugar because she never changed her eating habit, or that life cycle issue never changed. We go through, increased stress increases cortisol levels. What does that mean outside of the pregnancy? The stress, systemic racism hasn't changed where she lives. She's still dealing with that every day. Oh, I see what you mean. So it's taking the scenario just as a launching pad. When we look at some of these other statistics, what are some of the statistics that you're aware of that you don't see up here, or that is not maternal child infant mortality? Anyone? Okay, what about pain control in African American women? they're undermanaged, right? I actually had that slide and then I took it out because I was like, well, I don't know that I want to go there, but you brought it up, so I'm going to go there. But is it only African American women in pregnancy with pain control? No, right? We see that with every black person that comes through, they're either drug seeker or you're not in pain. So how do you get to the root cause of changing that?
I think that's a very good point. The ED, a black person comes in a sickle cell crisis, all of a sudden, oh man, they're drug seekers. They don't tell you what works, but yet, as a clinician, sometimes you're just like, make those assumptions just by what you see. And because somebody asked for a drug doesn't mean they're tell you that.
And hey, they know what works best, right? Good for you. That means I don't have to deal 4 hours of you in pain and nothing working. But why is there such a negative connotation to knowing what works for me? I've had sickle cell all my life. I mean, I haven't, but I've had sickle cell all my life. I know what works. I know what the crisis is. How many of your learners have been exposed to someone who's had a chronic illness at the age of 26 because they didn't get sickle cell at 26? They've dealt with it all this time. If we don't provide a frame of reference for them to go to, they're now experiencing it on the floor and they're perpetuating some of those factors. Can you imagine how frustrating it is if you just wanted Tylenol? You go to I have Motrin and Tylenol both in my backpack, probably multiple doses of different varying strengths. What happens when you're in the hospital and you have to rely on somebody else just to get you the basics, but they don't think you need the basics? How would you feel? Is that not frustrating? So you're not getting me at my best, you're seeing me at my worst and my highest level of pain, and you're not helping me in the least bit. But yet we expect a different level of return from that patient. Are we really training and educating our providers on how to deal with people at seeing them at their worst, not at their best? So I challenge you, when we give patients to learners in the clinic setting, don't give them the nice 80-year-old elderly white woman who says, sure, honey, take my blood pressure, both arms, 20 times each till you get it correct. Give them the complex patient. Give them the person who could use someone talking to them and hearing them, not just listening. So that's a challenge to you. So when we think about that and we kind of pull this through in this rapid discussion that we have in our time, thinking cultural humility, or should it really be cultural congruence? So first of all, I hate the word culturally competent. So you won't hear me say that because I don't think you can be competent in every culture. Cultural humility, that's great that we accept everybody's culture, but I want you to have culturally congruent care. I want you to take my culture into account when you're caring for me. I don't want you just to be cookie cutter for every person. Because if you know me and you know my culture, we're going to have a vigil around mom. I don't care if she's just in there pancreatitis. She's not staying there by herself. Now what do you do with mom and it's COVID and the family can't stay there with her? Does that put her at a different risk factor? What's your thought? You're shaking your head. Why?
I definitely think that she would be completely out of her element. How she's vulnerable. In her mind, she's probably terrified.
You know, it's one thing with COVID that we've seen a lot of. We just said increased stress increases cortisol levels. Increased stress increases hypertension. It is stress if my mom was in the hospital and no one was there with her. Because that is not part of their norm. That is not something that they're used to in their culture. So don't tell me now my blood pressure is through the roof. Yes, my blood pressure is going to be through the roof. But are there things that we could mitigate it? Are there things that we could do? She was so aggravated when she was at the beginning of the pandemic. She was hospitalized for something else. She was like, they want to give me insulin because my sugar is through the roof. I don't take insulin. Well, we know increased stress increases cortisol. Everything I just said, Mom, it's all right. Just tell them you'll work better on it and that you're not taking it. You have that right to refuse. It's okay. Because that was causing her more stress. And no one's really trying to understand where that patient is coming from. So all of those things start to come into play, but again, I then go back, are we providing a framework for our learners to actually learn how to manage that? We're expecting a 22-year-old nurse to go in there and manage that situation. Good luck. I'm 49, I can't manage Mom, so you try to figure that out. Or we have a resident that's going in and saying, hey, this is your insulin needs to happen. Well, no, it's not. Who's going to have that conversation if we never give them the opportunity? Especially cultures are different. How some of these young people interact is not something that would be going over well in my culture. So what they might think is normal would not fly. So now, how do you manage that? If we've never challenged their assumptions and their biases, how are we expecting them to be effective in the clinical setting? So, why does simulation give you the edge? Anyone have thoughts on that? Go ahead. Exactly. So, in summary, what he said, it gives them a safe container. I like to say that it provides a wonderful opportunity for them to feel exposed themselves. Because then the learner will say, oh, I don't like people watching me. You better get used to it. Because when you're coming into the room, you got the parent, the patient, and the neighbor if it's a double room. Someone's always watching you, so figure out how to get that comfort level here. And it's not, oh, you can hide what you said. Because now everyone's heard it and probably someone's recorded it already. So having real experiences for them, I think, is really important as we go forward. Now, when we start to think about cultural humility. This is me back home and in the islands. I was born and raised in America. Glad to be American, but very strong cultural household I grew up in. We went back and forth, so I can count in about 10 languages to the number 10, and that was about it. So in my formative years, we moved back full-time to the United States so that we could have a solid foundation. Truth be told, we lived on an island that was half French, half Dutch. We went to school on the Dutch side, and my brother couldn't speak fluent Dutch by grade 4, so my mom was like, okay, you're not staying back because you can't speak Dutch. We're going back home. So we came back to the United States. But all that plays a big factor into how someone is raised, how care affects our outcomes, but also on cultural humility. You have to understand where I'm coming from. I'm telling you where I'm coming from, but you have to believe me. So why is that important? Well, two things. We have these two people who are my mom and dad, by the way. My dad is from St. Martin, the French side of St. Martin. My mom's from Guyana. Raised in a strong West Indian home. What does that mean? Well, that means I have a hard time relating to the teens of today, where my parents were very strict. Got my first haircut when I was in high school, still don't wear makeup. And when I wear fingernail polish, my father still to this day has something to say about it. So understanding what's inside of someone is more than their skin tone. So I often say, don't judge me by my tonality. In a white and black America, I'm black. Then people look at me and say, well, you don't look black. Oh, please, let's have this conversation, is what I want to say. Because for people who are not of color, you need to understand the background and where that comes from in white and black America. And we want to talk a lot about culture, but we don't want to talk about the race that is the history that goes on beyond that. So what does the one drop rule mean and what does it matter? If you were allergic to chocolate and I put that one drop in that white cup, could you drink it? Most likely not. Would you drink it if you had a severe anaphylactic reaction? Would you take that risk? No. So as the variance of the skin tone of the chocolate milk, it's easier to identify because you're like, yeah, that's chocolate milk, not having it. But as the tonality of one's skin tone changes, you don't know what's inside, so you must ask. So the one drop rule, for those who didn't know, that's how the United States decided if you were white or black. If you had one drop of black blood in you, you were considered black and did not have the right to vote, did not have the right to purchase land. So when people say to me, well, I don't believe in the one drop rule, that's great, you don't believe in the one drop rule. But I wouldn't be able to vote, buy land, or anything like that. So, not that I like the one drop rule from what they had, but that's how it was based. So from early on, we, the United States, created constructs that we must dismantle now in order to do that. So the only way to do that is by asking someone, what are you? How do you identify? Why do you say you're Black Desiree? Well, my third grandma back was a slave. I mean, that's not something, we sit there, woohoo, about. Why? Why don't I? Well, that means my fourth grandma back was raped and beaten and burned as a slave. That's not something, but that's part of our heritage, and we don't turn away from that. And that makes people uncomfortable. So when someone says to me, well, you don't look black, aren't you Hispanic? No, that's my last name. Been married 30 years and I speak okay Spanish. But no, I'm not Hispanic. I'm Caribbean, born and raised in America. What else would you like to know? Now you say, ooh, this is kind of deep for the conversation you came. Well, that is my experience. That is my experience. It is my experience that in my electronic health record, I have white, black, Hispanic. Not one person asked. We look at COVID outcomes. When I went for my first COVID test, they wrote a little thing on my windshield, and I was like, what the heck is that? Not one person asked me what my race was. By the time I got up to the front, I couldn't take it anymore. We were at the convention center in Orlando, and they were like, oh, that's because you're white, Hispanic, and whatever other. I was like, first of all, I'm not white. Second of all, I'm not Hispanic. And third of all, why didn't you ask? I mean, I've been waiting here 2.5 hours, like you had plenty of time. So can some of our data be skewed? We're making assumptions. When we start to think about some of our lessons learned, we need to think about all things, not just race, ethnicity. You're assuming that English is my first language. Maybe it's not. Maybe I've worked so hard on not having any kind of identifier when I speak English. But yet, when we enter a hospital system, when we enter a clinic, what's your first language? If you say Spanish, that's the key for them to call for an interpreter. Who is our registrars in these places? High school graduates. They're deciding whether I need an interpreter or not. Now, that's not my story. That is my husband's story, who is a trained medical interpreter for the military, judicial, and legal. And oftentimes, he is provided an interpreter, and he's like, yeah, I don't need one. Yeah, but you said Spanish was your first language. Yeah. So it's all of these constructs we have to start to dismantle in education. So when I say one ripple at a time, it's truly one ripple at a time. So it really brings us to the point of how do we teach people to ask? In our session yesterday, the woman said, there was a participant who said, I hate it when people say, well, where are you from? Because they're not asking, where am I from? Because I'll say America, Connecticut, born and raised. No, they want to know, where are you from? Because you don't look black, you don't look what, like, are you Portuguese? So she exposed an implicit bias with me, so I'm assuming this is a safe container for me as well. So oftentimes as a clinician, I'll say to a patient, I hear a Caribbean accent. I see a bangle, so this is a very West Indian Guyanese tradition. All the women in my family have bangles on their right hand. I'm like, man, where are you from? Now, I'm coming from a place of love. I'm like, wow, you sound like my mom. And she made me aware, maybe not everybody takes it that way. So this was just yesterday, understanding that we have lifelong learning. How, even if I'm coming from a good place, how can your patient maybe take that differently? So how do we teach people how to ask? Do we provide the opportunity for them to ask? Now, here's a situation that happened. So that happens to be my grandpa, my aunt. By the way, I do have permission to share all these photos. They think it's quite funny, actually. So my aunt on the left, both of her parents born and raised in the islands. She is 100% Caribbean. She was intubated due to angioedema from being on an ACE inhibitor. So we know African Americans, black people, have higher risk with ACE inhibitors beyond angioedema. She was on it 8 years, and this was just last year that it happened to her. Not one person in her cardiac history asked her what her background was. They assumed she was Puerto Rican. So how did the rest of the family realize that they might have this sensitivity? Well, poor Aunt Lynn was intubated, and it went down the chain. I mean, I was last on the chain because my dad is her big brother. And he's like, hey, babe, am I on an ACE inhibitor? Or any of these? And sure enough, the entire family was on ACE inhibitor. Not one person asked. So how do we allow our students to practice these questions? Well, here's Dad. He's a ham. He loves to be in my scenarios. And we recreated him with a mannequin overlay. He swears we created him in a mannequin overlay. I should say we actually had that before he came there, but he thinks it's him, and I just let him go with it, yes. I mean, they do have the same gruff and whatever, but it's easy to include these scenarios. All we have to do is change the descriptors. We can talk about hypertension. We can talk about these things, but let's pull in the angioedema. Let's have that discussion as to why. Let's have the conversation about other things that can happen within your scenario and why it's important for them to actually ask. Now, all right, that's not working. Oh, it is. I just by chance happened to flick his foot, and he decided to cry. So when we start to look at our mannequins, oh, it's all right, Bob. It's all right. It's all right. I'm going to hold you this way. He likes to be held this way. Now, I can easily have him be a white mannequin. Why not have him be a different color mannequin? It's irrelevant to me having to hold him here. I'm desensitizing you to that everything needs to be a white mannequin. If color doesn't matter in mannequins, why make it matter? If the scenario is irrelevant, it's just a child that needs to be consoled. If you purchase diversity, oh man, sorry, Bob. My baby's 20, I can't handle this anymore. So if we have that ability, why not increase the use and normalize it for our students and our learners? Same thing in everything we do. If you're doing a demonstration, have a variety. Have a variety of pictures in your pre-brief. Normalize what does it look like to check a central line dressing on darker skin. You're not going to see if it's lightly pink around. What does it look like on different skin pigments? So as we start to look at our own implicit bias, I'm going to put you down. You can sit up. Don't freak them out by your blinking. So as we start to look at implicit bias in healthcare, where is it occurring elsewhere? What creates these implicit biases? Now, when you think about our learners, these are things that they're seeing. This so infuriates me, but I'm going to show it. Maybe. Oh, yeah. Check this out.
Can I get 10 large fries, please?
I'm gonna need like 10 Egg McMuffin sandwich things.
Night or the next morning, you've been loyal. My McDonald's Rewards is for you. Now every order earns points.
What did you guys notice in that? Let me show it to you again. Have a keen eye to who's in the video and who's doing what.
Can I get 10 large fries, please?
I'm gonna need like 10 Egg McMuffin sandwich things.
Night or the next morning, you've been loyal.
What's your thoughts? Hate that commercial, by the way. A lot of food. What does it imply? They're hungover or they're high, right? They got the munchies, they're going to McDonald's. That's issue number one for me. Why couldn't it be that they're just celebrating? But where's the white woman in this, or the white teen? She's in the back.
My McDonald's
What else she's
Rewards
doing in the back?
You. Now every
Once
order
they're
earns points redeemed
going for their
free
snack.
McDonald's.
Hang on. Wait. Okay, so pay attention to her.
Can I get 10 large fries, please?
I'm gonna need like 10 Egg McMuffin sandwich
This is
things.
the only one, not glasses, not
My
kind
McDonald's
of,
Rewards is for you. Now
just
every
say it
order earns
high,
points.
looking. So what images are we sending? This came out the week before Thanksgiving. I was sorry. I posted all over Facebook. I mean, I haven't seen it since, so maybe I'm like, why couldn't it be that she was just celebrating and they were going because the dollar menu's cheap? That's why my kids, they're like, hey, we all got $3. That's fries and a drink. Number one. And then why does it have to be all, not all in the second part, but you're going to make them appear high. So all these biases are subliminally all around all the time. That's McDonald's. That was, 10 weeks ago. So when we think about that with our learners, who needs to be involved in these simulations? How do we move this forward? Because I don't want to leave here in a, oh my gosh, humdrum type of, what can we do? So find people. The Laerdal eye scenario site has the gestational diabetes scenario. Get people. So these are my cousins. This is Shatasia and Sammy. That is their baby Cal. They lucked out. He is a professional actor, and I do have his written consent to have him on there. But baby Cal happened to be born right as we were publishing the scenarios. So I said to Shatasia, I was like, Tej, can I use your birth pictures that you posted on Facebook? They're like, yeah, absolutely, anything. She's like, because I've been following your research and it bothers me that we're at higher risk, but I've been asking better questions. So when I look at it, this is my family. This is my cousin, my first cousin. I'm happy that I'm making a ripple at a time, but it's because we share, we post, we make people aware, and the education, okay? Now, one of these things her and I chuckle about is a lot of people don't understand black babies aren't born with their full pigment. They're like, wow, what's up with that baby? You know, if they're never exposed to that to understand what does skin tone do, what does it look like, our learners won't know. Then, God forbid, they make the assumptions that has happened to my sister-in-laws. Yeah, is that your baby? Yeah, it's my baby. You know, no, I'm not the babysitter. So all those things actually happen in 2022 real life. Now, so be aware. What does it mean for you to be aware? Pre-brief them. Let your students be aware of what's going on. No one wants to walk into a sim scenario and then be, oh my gosh, this is what we're dealing with today. Now, it doesn't have to be outlandish. It could just be a simple article of what's going on. Now, in that healthcare disparity scenario that I run, oftentimes they don't even realize it's the healthcare disparity. They're focusing on the gestational diabetes and it's blended in, because that's how it should be, right? If we're doing it correctly, we're giving you the facts of all learners, all patients. Yes, if you're putting in healthcare disparities, implicit bias, or social determinants of health, you need to have an objective. You need to address it if you're putting it in there. So make sure you're taking the time to do that. So as we have 4 minutes left, I'd like to take any questions, if you have any questions for me.
Can I share an experience?
You can, but can you use the mic, please?
My name is Ken Miller. I'm from the VA, which we have a very big and I'm from Los Angeles, so we're very inundated with that. When I was a kid, I grew up in the 60s, and we started school desegregation. I grew up in St. Louis, and I remember being in first grade and walking to school, because I think bias is taught, like you said, from your parents, and so they desegregated our schools. All the parents were outside with signs, spitting on these black kids because they didn't want to mingle with us. I didn't understand it. And I remember sitting there, my teacher bought us all Christmas presents, and she bought all the boys a paddle with the ball on it, and she bought the girls coloring books. Well, a girl was sitting next to me. Her name was Antoinette. She was black. So I didn't want to take the paddle home because my mom would take the ball off and sweat us with it. So I wasn't dumb at 7. So I said, would you trade? So we traded, but she started coloring in her book. Now, she colored her people brown. That puzzled me. I looked at that and I said, Antoinette, why did you color him brown? And she goes, because I'm brown. And I'm like, oh. And she says, what color do you color yours? And I said, peach. And we both looked at each other and just kept going on. It's that simple. People don't realize that. But I grew up in I grew up in Ferguson, 2 blocks away from all that happened. And it's taught. And that's where we got to stop. We got to stop it in infancy and grow. And, I think it's better now than when I grew up, because that was when all that, the civil rights and everything.
I don't know, people are being murdered on the side of the street, dragged through neighborhoods, so I'm not sure that it's that much different.
Yeah, no, I'm not saying, well, anyway. No, I know, it is different. It is less acceptable. Back then, people pushed it under the carpet. But what I'm saying is it's taught. And that's how I changed myself, my views of what was inundated me when I was a kid and a teenager. And I think what blessed me more was traveling, seeing different cultures. So, but I think it's taught. I don't think it's something innate in us.
Thank you for that response. I think, too, though, there's privilege in being able to travel, right? Having that experience to even have transportation to travel to another town. So it's being aware some of our learners who actually get in front of us might not even have that experience.
First of all, thank you. This was awesome. I have a question on how you pre-brief when part of your simulation is to be having a discussion about implicit bias and without giving maybe something away within the scenario. I appreciate
So there's a lot of literature, and it comes really from the medical side. You can give learners a checklist, and they can memorize that checklist. And then when they come with all the realism, so environmental realism, contextual realism, doesn't matter, not everyone gets 100 because everything else factors in. That's number one. Number two, I think in your pre-brief, you can send articles or the implicit bias, hey, take this training before you come in, or take this test, and it doesn't really affect the scenario at all. It's more of a global overview. And that's what I've seen personally. I don't know if other people saw a difference. Good question. Anything else? Go ahead.
I'm going to try to protect. I don't know. As we get more funding, I'm going to work toward making our mannequins and simulators a lot more diverse. That right now there isn't the funding. And so I've been trying to really think about how can I start incorporating some things into labs that are maybe low cost, like the Black Lives Matter t-shirt on the mannequin, and making sure that I have maybe like a rainbow bracelet or something on, another one. Do you guys have any other ideas of ways to incorporate at least advocacy or things for diversity?
I think there are lots of things that you can do. It's not just about the moulage. It's about having that maternity scenario. And in the debrief, you choose to focus it on how would this scenario change if it was a 34-year-old Caribbean woman that just came here or relocated. So it's you as the facilitator shifting the lens. And as you get those mannequins and things, I mean, you can start off with a simple task trainer of an IV arm. One arm's $400 or whatever it is, and go from there. It also is the posters that you post around your sim center. In the pre-brief, when you're showing IV cannulization, what levels of skin tone are you showing? So simple things like that, or looking at diaphoresis or cyanosis, having multiple lip tones that are there, because you're not going to get pink lips on a black person to say that, oh yeah, they're not hypoxic. It's pulling in, and I can go on, I get passionate, so sorry, I don't mean to be yelling into the mic. I think also, pull in the discussions on the pulse ox. What's going on with the pulse ox? How would this change? Great, you got a SpO2 of 97. Is that a true 97? How would that change? And have those discussions from patho to physical manifestations. But anyone else, free fill. All right, perfect. Well, thank you all so much. Feel free to reach out. I look forward to our discussions.